We are live now, ma'am.
Okay. I just start the presentation. This is a small talk on adjuvants in poor responders. Basically, a poor ovarian reserve or a poor responder, because many times we are stuck with so many pharma telling us what all is good and what is not good and what can we use and all that. So this is a small presentation on that. So any adjuvant is a pharmacological or an immunological agent which will modify the effect of other agents. That is, you're using a main drug, and to increase the effect of that drug, you're adding something which is a pharmacological or a immunological agent. And why do you need to add adjuvants? Because you want an increased success and you want to decrease the complications which can happen. So the adjuvants can be divided as far as infertility is concerned as something which can increase the follicular output. And in a group of patients, it can also improve the endometrial receptivity. So for regarding follicular output, can be used for poor responders, normal responders, or hyper responders. And what is a poor responder? According to the Bologna criteria, the patient needs to have two of these following three, and one can be an advanced maternal age of more than 40 years or has got any other risk factor for a poor response, like endometriosis or an ovarian surgery or anything on the ovaries. Or suppose she has undergone an IVF protocol before, but she has given only 3 oocytes with a conventional protocol, then that is a previous poor ovarian response, and she comes into the category of poor responder. Sagiti, you have to mute the other people, huh? Otherwise it will disturb the talk. Sagiti? Sagiti, can you mute?
Okay, ma'am.
Okay. Or you can have an abnormal reserve test if you've done an antral follicular count test checking, or you have done an AMH level. An antral follicle count is only around 5 to 7 follicles, or the AMH is between 0.5 to 1.1. That means she's a person who's got abnormal ovarian reserve testing also. So what are the adjuvant therapies which has been advocated by Estray in 2019? Many have used growth hormone, some have used testosterone. Dehydroepiandrosterone is a popular drug. Aspirin addition in an IVF infertility cycle, indomethacin or sildenafil. Regarding growth hormone, it can act on the oocyte, can augment follicular genesis via insulin-like growth factor, and that is IGF-1, and can act by a direct action also. That is because the IGF-1 receptors are also present within the oocyte and in granulosa and theca cells. And in humans, it will promote the maturation of the denuded oocytes in vitro maturation treatment also. And intrafollicular growth hormone concentrations have been found to correlate to the results of conception IVF cycles. And that is why growth hormone is used to assist the low responder by increasing the recruitment of pre-antral and antral follicles who are destined to die. And that will also potentially improve the embryonic development because it got more follicles to work on. And the doses which has been advocated, it ranges from 4 to 12 units to up to 4 to 24 units, and that can be daily dose or alternate dose. So there are different protocols for growth hormone. And one RCT done in 2018 compared adjuvant growth hormone with no adjuvant treatment in an antigenous protocol. There's no significant difference in ongoing pregnancy rate or the number of retrieved oocytes with growth hormone compared to control group. So they didn't find much of use when they added growth hormone in different doses. But recent studies after that, a meta-analysis in 2018, Cozzolino et al. Study in 2019, the Ang study of 2020, and when they were published in 20, they demonstrated significant increase in the number of oocytes collected, less requirement for medication before oocyte retrieval, and an improvement in the clinical pregnancy rates. But they all are differing conclusions with respect to the live birth rate. So clinical pregnancy rate were increased, but they did not reflect on a higher live birth rate when compared to a placebo. And there is good evidence that growth hormone increases the number of oocytes retrieved and the clinical pregnancy achieved. But as we know from the studies, it's not a robust data as far as live birth is concerned as a primary outcome. And it's quite a costly drug. And there's no clarity on when to start the dose and the duration. Sakiti, please tell me when Dr. Padmareka joins. Sakiti? Sakiti? Sakiti?
Yes, ma'am.
Please inform when Dr. Padmareka is joining.
Sure, ma'am.
I'll wind up at that time. Yeah.
Okay, ma'am.
Yeah, thank you. And the next drug which has been trying for a poor responder is androgen. And androgens are supposed to play an important role in ovarian physiology and follicular growth. And research on primates has shown that androgens are likely to act on folliculogenesis because they increase the number of FSH receptors which are expressed in the granulosa cells. And that's why when you add androgens and ovarian stimulation, because they increase the number of FSH receptors, there will be a synergistic action along with FSH in follicular recruitment. So you may get more follicles than whatever is actually you can get with a regular conventional stimulation. And the first drug is testosterone, which has been administered transdermally as gel or patches. And it's been given from 10 to 12.5 milligram per day of gel for 15 to 21 days during the pituitary downregulation. Or you can add 2.5 milligram testosterone patches for 5 days during pituitary downregulation before gonadotropin stimulation. And that is a Kim study in 2014. But there was no difference in the live birth rate with 3 weeks of testosterone pre-treatment compared to no pre-treatment. And that's why ESHRE does not recommend testosterone as an adjuvant in poor responders. The next drug is dihydroepiandrosterone, used at a dose of 75 milligram per day. And it varies in duration. You can give it for 6 weeks, 8 weeks, or 12 weeks before the start of ovarian stimulation, and also can continue during ovarian stimulation. But most of the studies have done with DHA of 12 weeks duration prior to ovarian stimulation. And 2 RCTs reported conflicting results. The first RCT said there's a beneficial effect of DHA on clinical pregnancy rate. But the second RCT said there's no significant difference in the live birth rate between DHA and a control group. And that's why ESHRE in 2019 has said, even if you give DHA before or during an ovarian stimulation and during an ovarian stimulation, it is probably does not have much of an effect and is not recommended for poor responders. The next drug which we commonly use is aspirin. It can work by inhibition of prostaglandin synthesis by blocking the enzyme cyclooxygenase. And there are other proposed benefits of this drug that they say it can improve the uterine blood flow, can inhibit thromboxane synthesis to prevent placental thrombosis, and can also enhance endometrial receptivity to promote implantation. Doses can be 75 milligram, 80 milligram, or 100 milligram. And it is continued until HCG administration for final oocyte maturation, or can be continued till 12 weeks of pregnancy or even up to delivery. But the routine use of aspirin as far as IVF is concerned is controversial, and there is no evidence in support of using aspirin to improve the live birth rate or reduce miscarriages in women undergoing IVF. It has been widely used in contemporary practice, even though there's no proven efficacy of this drug as far as its work as an adjuvant is concerned, and safety data is also limited, and current evidence does not exclude the possibility of adverse effects. And ESHRE 2019 said that giving
Excuse
aspirin.
me, ma'am.
Padma
Padma ma'am has joined.
Okay. Yeah. I'll stop sharing. Welcome, Padma. Hello. Dr. Padma.
Let me unmute myself.
Yeah.
Can you hear me now?
Yeah, we can hear you. Yes.
Okay.
Okay.
So
I will just introduce you, Padma, then you can start. Welcome to the program.
thank you very much.
Thank you.
And my sincere apologies.
No problem.
It was a medical emergency and I was
know.
at the tail end of that.
Oh, I know. Thank you so much for joining. It's an honor to have Dr. Padma Rekha Jirge with us. She's a great academician and she is a research fellow from University of Glasgow. She has done a MSc Epidemiology from the University of Edinburgh. And she's also the scientific director at Sushruth Assisted Conception Clinic and Shreyas Multispeciality Hospital and Research Institute, Kolhapur. And she's a founder director of Prismatic Research Foundation. She's got several publications, and the first one is on genital tuberculosis, which affects the ovarian reserve in infertile women, and that was published in Human Reproduction in 2018. And she's also had several publications in various international journals. And she's been the president of the Fertility Preservation Society of India. And I'm sorry, she's currently the president of the Fertility Preservation Society of India. She's a chairperson of the Maharashtra chapter of ISA 23 to 25. Has been the chairperson of the SIG Reproductive Endocrinology Committee of PCOS Society of India. And she's been the immediate past editor-in-chief of the Journal of Human Reproductive Sciences. And she's been responsible for the journal procuring an impact factor. And she's also deputy editor of the Fertility and Reproduction official journal of Aspire. Welcome, Dr. Padma, to this program. This is called as the academic wing of assisted reproduction, and it actually caters to rural reproductive medicine specialist of Tamil Nadu. So we are basically the south of Tamil Nadu outside Chennai, and we join in numbers basically to interact with great clinicians and academicians like you. Welcome to the program.
It's very kind of you, Dr. Charmila, for having me here. And I'm very impressed by the fact that you have got a group which sort of is towards hardcore science. I think rural or urban, all of us face similar situations. To be motivated and to be committed to something like this. I was just about to ask, can anybody become members? But you
Yeah,
you did
anybody
say.
can become, no, anybody can become a member. We don't charge anything. And we just do webinars. We don't have physical meetings where we drink coffee and eat food. We just come to listen to great talks and go back in an hour and then come back for the next month. We don't have any physical meetings at all. It's only webinars.
I'm very, very grateful that, like you have invited me for this. And I hope, I do live up to the expectation and contribute towards some kind of knowledge about this intriguing thing. For me, tuberculosis and infertility is a very intriguing thing. I'm not sure exactly. Can I start sharing my
Yeah,
slide?
you can start sharing. Yes, please.
So,
It's visible. Yeah.
yeah. So,
Can you make it into a slideshow?
yeah, I will do that. I'll do that.
Yes.
So, because you introduced me, like I just want to say that all my training happened in UK, all my postgraduate training. So after my graduation from Bangalore Medical College, I went to UK. And when I came back and I saw so many people getting all sorts of treatments for tuberculosis, I used to believe, very sincerely that, they are being overtreated. But my understanding was very wrong. What I should have thought is the treatment is not maybe being done appropriately, but definitely they probably were not being overdiagnosed. So it was in 2008 where for the first time somebody with unexplained persistently thin endometrium, I thought I should investigate for tuberculosis, and that's how my journey about learning about this genital tuberculosis started. And now, if you say Mycobacterium tuberculosis, I'll stand up in attention. So that is the amount of havoc this little Mycobacterium plays in our life. And you did mention that I should talk about the work I have done, the original work I should discuss. So I've put only those many slides. So that's where I started thinking about it and started reading about tuberculosis. And now we know that India has the highest burden of tuberculosis, contributing to about 27% of the global population affected with tuberculosis. They live in India, and incidence of TB in India is 199 per 100,000 population. So it can be geographic variation can be anywhere from 169 to 231. Genital tuberculosis, we know, is the commonest form of extrapulmonary tuberculosis. And I think about 25 to 27% of the cases reported of tuberculosis contributes to, is contributed by extrapulmonary tuberculosis. What we know from the conventional publications is that, or textbook reading is that tuberculosis contributes to about 5 to 20% of female infertility. And the Index TB guideline, which is the overarching document for managing tuberculosis in India, published in 2016, says that infertility may be the only symptom of genital tuberculosis. Why, if it is such a common condition, why are we struggling to identify that? So this is a very typical thing which we're all used to, like it causes, it's a common cause of infertility and common cause of failure of treatment, including failure of IVF. And we all say this, in 90% of the people, fallopian tubes are affected. In about 50%, endometrium is affected, and ovaries are affected in about 30% of the people. So this 30% of ovarian, it's only ovarian affection happening in 30% of the cases comes from an era where we did not have any way to assess biophysically or biochemically the ovarian function. So we used to go by what we diagnosed either at laparoscopy or at laparotomy as tubo-ovarian masses or so-called oophorytis, maybe on ultrasound, initial days of ultrasound. So surely it cannot be that 90% of the times tubes are affected and only 30% of the times ovaries are affected. Because, ovaries, if you look at it, very good vascular supply, very good hormonal environment. The corpus luteum must be, full of nutrition for this bacteria. So it is surprising that only 30% of the time ovaries get affected. So why are we unable to detect the ovarian affection of tuberculosis? Is that obviously the condition is paucibacillary. Fallopian tubes and ovaries cannot be biopsied. And of course, like the diagnosis is what we do through endometrial biopsy, and we may easily miss an area of infection. So the challenge is because, I have put it as latent tuberculosis. That is what my work was on, the initial work was on. And very soon, we will be removing the word latent and probably propose the word subclinical, because latent tuberculosis in any part or any other part of the body has a different meaning. So we should not really be using latent word anymore for genital tuberculosis, and maybe we should say subclinical, basically meaning the structures look okay, but there is tuberculosis present. So as I was mentioning, the genital area is very, very lucrative because of the hormonal environment and vascularity. And we all have studied, as from our studentship days, that there is altered local immunity in women with infertility. So pelvis appears to be a very, very good area for this Mycobacterium tuberculosis to lodge itself. And what we know from this latent tuberculosis is that it's not a quiet or dormant condition, because the host tissue is there is an immune response happening mounted by the host tissue when there is Mycobacterium tuberculosis present there. So even if there is no structural damage visible, there is an immune response happening, and that does lead to local tissue damage. So it's not a quiet condition. So it is extremely important that we need to take this into cognizance while we are thinking of ovarian affection. So, but now we are in an era where we can assess ovarian function. We know that AMH basically looks at all the pool of growing follicles within the ovaries, from primordial follicle to when they move into growing stage. We can actually identify that stage. So if there is any damage happening at a microscopic level, obviously we can't biopsy, we can't detect the bacteria, but certainly these two robust markers like AMH and AFC should be giving us some evidence as to whether there is ovarian affection happening at the at a subtle level. So this was the study we did looking at latent, that's what I was saying, we named it as latent tuberculosis adversely affects ovarian reserve in infertile women. So what we did was we looked at women with more than 2 years of infertility, documented laparohysteroscopy within the last 1 year or so to be included in the study. They needed documentation. Either a clinician has documented it, or they had a recorded video of that procedure, or they underwent laparoscopy within our clinic where we had documented that everything looked normal. So so-called unexplained infertility. And in that scenario, they should have had at least 6 months of documented treatment for infertility in the form of ovulation induction or IUI. So these are women who would be otherwise named as unexplained infertility and had received some amount of standard treatment but had not conceived. So this is the subgroup of women coming to our clinic we chose. And this was a prospective cohort study, and from 2013 to 2016. And they were compared. They were compared with these women then underwent endometrial biopsy, an outpatient endometrial biopsy, or if they were undergoing laparoscopy at our clinic, the biopsy was done at that time. So the total number of women were around 800 plus women. And depending on the biopsy result, we subjected them to DNA PCR and histopathology. During this course, we did not find even a single positive diagnosis of granuloma on histopathology. But so sole diagnosis was based on DNA PCR. So there were women diagnosed with tuberculosis 431 versus 453 women without tuberculosis. So that was group 1 versus group 2. The age group was between 21 and 38 years of age. And that group, obviously after diagnosis, they received standard ATT. But at baseline, while we were performing the endometrial biopsy, they also underwent ovarian reserve testing. So the ovarian reserve testing was done in the form of FSH, basal FSH, LH, AMH, and antral follicle count. At that time, the assay used was the Gen2 assay for assessing AMH, which was an ELISA. So if you look at the group 1 and group 2 here, if you look at the various box plots, as far as FSH, there was no difference. As far as AMH, we can see that there was a significant difference. AMH was significantly lower in group 1 compared to group 2, and so was AFC. There was a significant difference between this. And then what we did was we subdivided this group between as those who had no PCOS and those who did not have PCOS, those who had PCOS. So again, the difference was noted in those who had PCOS as well, that the AMH was, obviously the AMH was higher in women with PCOS compared to those who did not have PCOS. So the whole group showed a difference between those with TB and those without TB. And also after we excluded PCOS, again the group which did not have PCOS showed a significant reduction in AMH and AFC compared to those who did have, after excluding PCOS, the group with TB had lower ovarian reserve compared to those who did not have tuberculosis. One of the interesting factor in this group was there was no difference in the demographic data between these two groups. Those who had tuberculosis and those who did not have tuberculosis, the distribution amongst urban and rural population was exactly the same. BMI was same. Only difference was that the women with tuberculosis were 1 year younger compared to those who did not have tuberculosis. So this is even more worrying. So younger women having significantly lower ovarian reserve. So we were finding something that was worrying. And then we looked at what was happening to the pregnancy in these women. So if we look at group 1 and group 2, total pregnancies were following treatment. Obviously, women with tuberculosis started receiving ATT. They received 2 months of intensive ATT, that is 4 drugs, and followed by 3-drug regime for the next 4 months. So when we looked at that, total number of pregnancies were out of 395, women who completed the study, 204 conceived, that is 51.6%. Whereas group 2 just went on with further treatment, either in the form of ovulation induction or IUI or IVF, and we achieved a pregnancy of 40.5%. So this difference was significant. And then if we looked at ovulation induction, I mean, those where we found, obviously they were otherwise named as unexplained infertility in both these groups. So if we gave them a short course of ovulation induction, again, the pregnancy rate was significantly higher in group 1 compared to those who truly had otherwise unexplained infertility. IUI pregnancies, there was not much of a difference between these two groups. Of course, IVF showed a better pregnancy rate, significant difference compared to truly unexplained group. So this is like out of 137 women who underwent IVF, 94 conceived. That this is with their own oocytes. That is 68.6%. They might have had more than one cycle of IVF. This is cumulative pregnancy rate. and compared to 48% in group 2. Again, this was significantly higher though in those who were treated for tuberculosis. And then a percentage of them had very low ovarian reserve and had to undergo IVF with egg donation in both the groups, and the pregnancy rate did not appear to be different in this subgroup. Miscarriage was non-significantly lower in women who had a diagnosis of tuberculosis and treated for the same. Now, going into more details about, just before I go into the details of our study, at this juncture, I want to make a comment here about there is a systematic review which has been done recently, wherein this study also was one of the original studies included, and the authors have commented that this study was the one which did not have any kind of because in systematic review and meta-analysis, they look at risk of bias. This study did not have any, it was low risk of bias from recruitment to reporting, there was low risk of bias all along. And also that systematic review shows that for some reason, women diagnosed with tuberculosis and treated for the same either have a better chance of achieving spontaneous conception or with IVF, and IUI for some reason appears to have the lowest success rate. And that is an important information we need to have, because it's very tempting when they have normal looking tubes and patent tubes to take them through protracted cycles of IUI, and maybe that is something we need to change in our practice. So if we look at the subset of women who underwent IVF, so let us look at the whole group as such. Group 1, those who had tuberculosis, and group 2, who were truly unexplained infertility. Number of cycles, as I showed earlier, 197 versus 200. The total number of total amount of gonadotrophin received was non-significantly higher, obviously because their ovarian reserve was lower in this group. Total oocytes were significantly lower compared to those who did not have tuberculosis. M2 oocytes significantly lower. Embryo transferred was more or less similar in both the groups. However, grade 1 embryos were significantly higher. Implantation rate was significantly higher in group 1, that is in those who had tuberculosis. Again, we excluded, because this was complete group with and without PCOS. So when we excluded PCOS and we looked at it, you know that the, number of oocytes will fall in both the groups. That was the case. Without PCOS, the number of oocytes retrieved were again lower. Again, these women with tuberculosis received more higher dose of gonadotrophin, lower number of oocytes, lower number of M2 oocytes. Embryo transferred was significantly lower, but the implantation rate was significantly better. Quality of embryo was better. So that is something very important to understand. And we looked at those who were pregnant and those who were not pregnant, and looked at what was happening to the AMH. So if we look at AMH in non-pregnant women in the whole group, AMH was better. We know that those who have better AMH have a better pregnancy rate. But look at this subset of women who did not have PCOS. After we excluded PCOS, there was no difference in AMH between those who conceived and who did not conceive. But obviously, we have achieved better pregnancy rate. So there appears to be a qualitative improvement happening here, because this was not a longitudinal study. We did not see what happened to AMH after we cured and we followed them up. So higher pregnancy rate was achieved in these women despite lower AMH. So that is something very, very interesting. So the logical continuation of this study was to look at what happens to ovarian reserve in and pregnancy outcome if we follow these women up longer. So this was the topic of my dissertation. Again, Charmila mentioned about me doing this epidemiology from Edinburgh University. So I took up this study Do I have 5 more minutes, Charmila?
Yeah, you can take your time, no issues at all.
Yeah.
Please take your time.
So what we did was this study included normogonadotrophic infertile Indian women between the ages of 21 and 40 years, all infertile women from 2021 July to December 2023. Those who had a baseline serum AMH tested around the time of endometrial biopsy for the diagnosis of GTB, and every 6 months thereafter, up to a period of 18 months, were included in this study. 230 women were diagnosed to have genital tuberculosis, that is group 1, and the remaining 214 in this study, that is group 2, did not have genital tuberculosis. So if we look at what is happening longitudinally, AMH 0 is around the time of endometrial biopsy, within 1 month before or after endometrial biopsy. AMH 1 was 6 months. So that is those who were receiving ATT at the end of ATT, and again 6 months later, that is 1 month, that is 1 year from the initial recruitment, and again 18 months at from the recruitment. So in group 1, we see that the AMH, if we compare group 1 and group 2, the AMH was lower at at the beginning of the study, and then we look at at the end of ATT followed by 6 monthly reporting. So we see the AMH gradually improves with those who had tuberculosis, and with group 2 who did not have tuberculosis. Obviously, with ovarian aging, we would expect the AMH to go down. So AMH from 0 point to AMH 3 in group 2 reduced successively, whereas with those who had tuberculosis, the AMH showed improvement. And between groups, whatever difference was noted at the beginning disappeared. So if you see, initially those who did not have tuberculosis had better AMH, as we had seen in the first study also. But here, gradually over a period of time, AMH in group 1 improved, so it became better than group 2. So there appears to be something that is happening with tuberculosis and with treatment, which is improving the scenario. Then with epidemiology, what they look at is a dose response, dose effect response. So we looked at in this study, in the first study I presented, we had taken only those women who were diagnosed as otherwise unexplained. That is, those who did not have any damage, visible damage to the genital tract. Whereas here in this study, we included all women diagnosed with tuberculosis with or without structural damage. So we see here that across all parameters, across all time periods, those who had latent tuberculosis had better ovarian reserve compared to those who had structural damage. So that there appears to be some level of dose effect response. So as the structural damage increases, the chances of having lower ovarian reserve increases. So another evaluation we did was, we know that we classify women below AMH of 1.2 as having low ovarian reserve. So what was the percentage of women having low ovarian reserve before starting ATT, and what was the percentage after completing ATT? So if you look at this first bar diagram, we see that the percentage of women having poor ovarian, diagnosed with poor ovarian reserve, was significantly higher compared to those who did not have tuberculosis. And here we see that this third bar has come because in all longitudinal studies, we always have some dropouts, and the dropouts go on increasing as the duration of follow-up increases. So there was a percentage of dropout in both the groups. But here we see that the number of women having poor ovarian reserve decreased in women with tuberculosis after they completed the treatment. So there is also one study, very small study from AIIMS, which has looked at 0 and at 6-month period, and they have shown some improvement. But this till date is the study which has gone on the longest. And this, I think these box plots are much more impressive to look at. So as we see, the patient density is very high at 0, because all patients were represented here. So women with structural damage had the lowest ovarian reserve, followed by those who had latent tuberculosis, and the highest AMH was noted in those who did not have tuberculosis. So when we start looking at the other box plots here, the dynamics start changing. So as they completed the treatment, AMH in those who had structural damage or no structural damage, those who had tuberculosis started improving, and age-related decline started showing up in those who did not have tuberculosis. As we see the third and fourth graph, we see the patient density is low. This is partly because some of them would start getting pregnant in both the groups, and also they get fed up and start dropping out as well. So the compliance also gets affected. So both these factors affected the number of patients in the third and fourth time point have reduced. But we can see a distinct improvement in AMH in those who had TB and received treatment for tuberculosis compared to those who did not have tuberculosis. So you can see that, the initial graph was highest AMH in those who did not have tuberculosis, and the dynamics have changed subsequently. Now, how important is it? Is it really clinically meaningful? Or is it, all this is because of something else? So what we call as, whenever we look at anything, there can be confounders. Somebody, television watching and coffee drinking could be, we may say that those who drink coffee may watch television longer. But there can be another element, that maybe there is an element of depression, and that is making them drink more coffee, and they're they're not sleeping well, and that is why they're watching TV. So no equation is as simple as it seems. So there are always some confounders. So the equation may not be as simple as that. You have TB, so your ovarian reserve is less, because we know that actually age has an impact on ovarian reserve. BMI may have an impact on ovarian reserve. Having a diagnosis of PCOS will have an impact on ovarian reserve. Endometrioma surgery can have, presence of endometriosis can have, tubal infertility due to any other cause may have, and unexplained infertility. So we took all this as confounders or the variables, and we did a multiple regression analysis to see which of these factors in our patient population were affecting ovarian reserve. So PCOS diagnosis has a positive correlation with ovarian reserve, but age and the tuberculosis, presence of tuberculosis. So if somebody did not have tuberculosis, she is likely to have an AMH 0.59 nanogram, better AMH compared to somebody who did have tuberculosis. That is the explanation for this table. So if somebody had tuberculosis, she is likely to have, compared to somebody with similar age and weight, her AMH is likely to be reduced by 0.59 nanogram per ml. What does this mean clinically? We know that the AMH in its natural course declines by 0.16 nanogram per year. So this is worth 3 to 4 years of loss. So somebody who has tuberculosis is ovarian age-wise, she is 3 to 4 years older to somebody who doesn't have tuberculosis. So that is a major impact. When we look at 0.59, it doesn't appear to be much, but that is the impact tuberculosis is having on the ovarian aging. So this is what my work so far has been. And with this work, we also now have had a consensus as the chairperson of MSR. I had the what should I say, pleasant experience of conducting a Delphi consensus. All the experts who have had any previous publication on genital tuberculosis and infertility were invited, and we had a very 2-day nerve-wracking discussion about how we are going to diagnose tuberculosis within the context of the guidelines we have in the country, and what are all the parameters we need to look into, because there has been no parameter which has been included. We look at HSG, we look at hysteroscopy, we look at laparoscopy and make a clinical diagnosis, but we just don't look at ovaries at all. So with Delphi consensus, we need to achieve 75% consensus with all the experts, but we set the consensus bar higher for this consensus group, and we set it at 80%, and more than 80% of the experts now with the available evidence have said that we should look at ovarian reserve, and unexplained reduction in ovarian reserve could also be a pointer towards presence of genital tuberculosis. So this has been my work, and I'm very grateful, Charmila, for giving me an opportunity to present this.
Thank you so much. Can you stop sharing, Dr. Padma?
Yeah.
Wonderful study, I would say, such a genuine work. And there are some questions in the chat box. Would you mind answering them? Is it okay?
Yeah.
Dr. Indira Prasad has asked, what was the test for diagnosis of genital tuberculosis in those patients?
Okay. So, whatever we do for genital tuberculosis, because it is a national program, we need to follow the national program. So the national program says microbiological diagnosis can be through bacterial culture or through GeneXpert or TrueNAT, which are, it doesn't stop at that. It says any of the NATs, that is nucleic acid amplification test. What test we did for this study purpose is multiplex DNA PCR. So the national program says the advantage of identifying the bacteria through BACTEC or any of the liquid cultures or through GeneXpert or TrueNAT is that we get the rifampicin or bacterial sensitivity or resistance. When we do any multiplex DNA PCR, we don't get to know the bacterial sensitivity. That is the downside. But at present, neither TrueNAT nor GeneXpert is geared up to lyse the endometrium and extract the bacteria. That is why the detection rate is very low.
So you use the multiplex DNA PCR.
Yeah.
So we can use it then, all of us then, suppose you want.
So what the consensus, the consensus that has arisen is, as long as you have done at least one of the recommended tests, like the bacterial culture, you can do anything else and treat, but register them in the national portal and report them as either clinically diagnosed or what they call as probably diagnosed if none of the tests are positive, by microbiological tests are positive, or definitive diagnosis. If either NAT or culture is positive, then they're definite diagnosis.
So you need a bacteriological diagnosis to start your treatment, right?
See, originally we used to say bacteriological diagnosis has to be only through culture. Now they have said histopathology is also okay.
Exactly.
If you have said granuloma is present. Yeah.
Okay. Jem, madam, I'll just come to you. I'll ask the next question, come back. One question is if you started ATT, how many months did you give?
It is standard ATT, 2 months of 4-drug regime. That is INH, rifampicin, ethambutol, and pyrazinamide, and 4 months of 3 drugs. Many times, long ago we used to do 2 drugs, but the recommendation is excluding pyrazinamide, all the other 3 should be included.
Dr. Jayamkaran is a vice president of the society. She would like to ask a question. Madam, please unmute yourself and ask. Madam, not unmuted. Madam, you have to unmute yourself. Unmute, madam. Not unmuted. You have to unmute. No, we can't hear you. Madam, unmute, madam. Have you muted everybody? Sahiti? Is she unable to unmute? Sahiti? Sahiti? Sahiti, where are you? Sahiti? Shanti Priya, just try unmuting yourself. Shanti Priya. Shanti Priya. Shanti Priya, try unmuting yourself. I think there's a problem. Sahiti, please unmute Dr. Jayam Kannan. Okay, I'll just call her. But before that, there's one more question like, can we start anti-tuberculosis medicine in unexplained infertility patient arbitrarily?
What the guidelines say is that if there are no pointers, like HSG is normal, ultrasound is normal, laparoscopy is normal, and all the bacteriological tests have come negative, then I think we don't have any standing to start ATT. But the guideline permits a clinician to take a decision clinically and say that I will treat, but we have to label that as clinical diagnosis, which means bacteriological diagnosis is lacking. Register them on the national portal and then start the treatment, not to do sort of, like short courses, 15 days, 2 months or anything. But we also have, and also we have to remember that all these medications may have their own set of side effects. So counsel them properly and through the national portal itself do the treatment.
Muted. Can I talk?
Unmuted yourself. Yeah.
Can I talk? I am unmuted. Can I talk?
Yes, ma'am.
Yeah, Padma. See, what has of late happened is, since we are not able to report these cases with the histopathological diagnosis or with any clinical array, in two of my patients, I had to refer the patient to pulmonologist. When all the NAT, everything came as negative, still I felt that the patient has a mother who has been treated for tuberculosis. So I had to send her to the pulmonologist. Pulmonologist was somehow able to start the patient on anti-tuberculosis treatment, and now after the treatment, patient has conceived. So how is it that this we took it as a shortcut, but is it the shortcut every time to happen?
It's a very fine balance, ma'am. I mean, we all have had the experience. I mean, we should not be treating anybody randomly. As you said, you took all with due diligence, you investigated and you counseled the patient. So what the guidelines say is if we follow the algorithm that has been provided by the Ministry of Health and Family Welfare, if the clinician still feels that the patient has tuberculosis, the right thing you have done is take the help of the pulmonologist or a physician and register them on the national portal so that it is declared as whether it is clinical suspicion or some diagnostic test proved that tuberculosis, so that they can distinguish how many people are getting treatment as clinical diagnosis and how many are bacteriologically confirmed. But
Thank you.
it is a very difficult diagnosis very often.
Yeah. I just wanted to pass on this information so that other clinicians, if they find difficult, they may seek the support of a pulmonologist also, which is this thing in that portal is accepted for registration in the National Registry.
But it's a mandatory that everybody registers the patient in the portal. Don't just start arbitrarily like we were doing 10 years back. That will be a problem.
Because then we will lead to resistant, strains growing. So we just make the matter worse.
And Madam has lauded your paper on excellent studies on AMH and tuberculosis, Jayam Kannan, Madam.
Thank you,
Then
ma'am.
Dr. Sharada Ray has asked sorry, I already answered. Dr. Renuka Mogan is asking, a patient who's 25 years old, married for 4 years, had persistent fluid in the endometrial cavity, tried 8 cycles of ovulation induction with a natural cycle, and then, natural cycle, and then 3 IUIs done, 2 IVFs done, endometrial biopsy for tuberculosis PCR was negative. Can we start ATT for her? AMH is declining over 2 years.
So I would say, we should make an effort here. If there is fluid, we can aspirate that and send it for culture, because with any of the fluid, detection with culture is much better. And DNA PCR, I mean, one of the things with PCR is how many probes we are using, because apparently we have 3 different strains of Mycobacterium tuberculosis in the country. So one of the things is to, like, subject her to like a histopathology and culture. And if it is a multiplex DNA or nested DNA PCR, that has a higher pickup rate. If it is not, I mean, if we have ruled out structural damage, if there is no addition there, if we have ruled out hydrosalpinx, because that's the commonest source of persistent fluid in the endometrial cavity, then I think, again, like what we discussed earlier, we will have to treat her as clinical diagnosis, report, register, and then do the treatment.
Renuka, I think you got your answer there. Madam has asked, like, extragenital tuberculosis diagnosed and managed, what is the chance of getting genital tuberculosis even after a full course of treatment?
I think what they say, ma'am, if there is a gap between the previous diagnosis and now of 2 years, they consider it as a fresh infection. But if it is detected within less than 2 years of the original diagnosis, they consider it as incomplete recovery, or so it has to be considered as a continuation of the previous infection itself.
Okay. And
It's a very difficult scenario, because what treatment they would have received for any other extrapulmonary tuberculosis might be very different to what we have used for here. And at this stage, what we have to use here. So at this stage, it's very important to try and do identify, antibacterial sensitivity. And soon we might, in these kind of challenging situations, we might be able to do NGS. If we get the bacteria, do an NGS and look at the sensitivity, antibacterial sensitivity.
Thank you.
Actually, Dr. Renuka, she should take more of samples now, right? From some tubes, from the endometrium, and subjected to for more testing before she can go ahead with anti-tuberculosis treatment. But without a diagnosis, you have to be very, very careful when you're giving an anti-tuberculosis treatment. Okay. Dr. Sharda Ray has asked, can TB be the reason for low AMH in very young women whom we see nowadays? If yes, how do we go about it? Why should you check for low AMH in very young women?
I mean, I was going to say, I mean, I'm assuming very young means less than 25 years. And we know that AMH peaks only at 25 years of age. So it could be a physiological low. The second thing is, many of these girls can be on oral contraceptive pills without actually revealing that they're on the pill. So that could be one another reason with while they're on, or recently if they've been an oral contraceptive pill, again, that can be a reason. Obesity can be a reason. So I think we need to look at what are all the established causes of low ovarian reserve, and don't, blame TB, implicate tuberculosis in every one of them. But I think a small percentage of them will be having it.
Yes. And Dr. Jayashree Sridhar has asked, like, in a high prevalence country like India, are we allowed to give AKT for latent tuberculosis?
Yeah, that is why we are going to change the nomenclature from latent tuberculosis to subclinical tuberculosis, because in the context of genital tuberculosis, we are not actually talking about latent tuberculosis as they speak in pulmonary context. So that's why the consensus group has proposed that we should not use the word latent, we should use subclinical, because we know even at subclinical level it is damaging. Yes. But of course, in latent tuberculosis in any other part of the body, they would receive some kind of prophylactic therapy.
Correct. Dr. Jayashree Sridhar has again asked, like, did any of the patients of IUI have sonographic evidence of genital tuberculosis, like cystic lesion in the myometrium, subtle irregularities in the endometrium, translucent follicular rim, cervical fibrosis, etc.?
So the first study I presented, where we critically looked at only unexplained infertility, none of these, no HSG abnormality, uteruses looked normal. And then, that is one thing I look at, especially HSG, I look at that subtle irregularity. None of that was there. But in the second study, where we did the longitudinal study, where we included anybody who was diagnosed with tuberculosis, some of them did have either, some of these features.
Dr. Deepthi Rati is asking, like, in which phase of the menstrual cycle should an endometrial biopsy be taken?
Yeah, this is one of my favorite questions and favorite dilemma as well, because this I've discussed with Dr. Nalini Mahajan, Firoza Parekh, many of them. And now, so see, we know that WHO and CDC say that we should not take menstrual blood, definitely not menstrual blood. So I follow the principle that anytime they're not menstruating, I mean, definitely not immediately post-menstrually, because laparoscopies I would always do in the follicular phase.
Yes.
I don't I think all of us stick to that rule that in an infertile woman, we won't do laparoscopy in the luteal phase. So I would take biopsy at that stage. So I would say late follicular phase or luteal phase. If I've done an outpatient biopsies, invariably it is around day 18 to day 21. And also I have a large population of women, large percentage, I should say, not population, of women coming from 400 to 500 kilometers radius. So, to see them today when they are day 14 and say come back after 1 week if they need this biopsy, it is a bit too much. So I do use it at times opportunistically. But by and large, late follicular phase, if I'm doing laparohysteroscopy, outpatient biopsy, if I'm giving them an appointment in the luteal phase.
Luteal phase.
Yeah.
Yeah. What are the criteria for empirical treatment in infertility and how long? Dr. Annapurna says.
I think now we cannot use the word empirically, because we can use only two diagnoses. One is probable diagnosis. That is when bacteriologically we have not been able to confirm the diagnosis, but either HSG or clinical suspicion is there, HSG or laparoscopic, hysteroscopic evidence is there. And now soon we will come out with the ovarian reserve criteria as well. So they are all pointing towards tuberculosis, but there is no bacteriological diagnosis. So that is probable diagnosis. Or if whether any of these signs are present or not, bacteriological diagnosis established, then it is definitive diagnosis. So these are the only two. Empirical, we should not use the word
empirical. Okay.
Because, there is a medico-legal context. I just want to highlight this, especially with ethambutol. There are two issues. One is ocular toxicity, where there can be permanent damage to the vision, and the neurotoxicity, hearing or peripheral neuropathy, which can be very, very prolonged. And any of them can cause hepatotoxicity, and sometimes it can be quite severe. So all these, of course, as clinicians, we don't want our patients to go through this, but they also have medico-legal implications. So I think
Dr. Padma, here yes. I am Dr. Tripathi, S.N. Tripathi speaking. One question to you.
Madam, 1 minute, can she finish her answer? Then we'll ask you. 1 second, madam. Please.
Yes, I am waiting.
Yeah. Yes, ma'am. Yes, ma'am. Padma, please continue.
Yeah. So we should not use the word empirical. We should document it as clinical diagnosis, means probable diagnosis or definitive diagnosis in our paper, and counsel the patient and register them and do the treatment. Please do not use the word empirical.
Tripathi madam, please unmute yourself, ma'am. Tripathi madam. Dr. Tripathi. I'll just unmute her. Madam, yes, ma'am.
Criteria of diagnosis. You have told empirical, that is very good. You have told everything, that is also good, but you cannot diagnose a case of tuberculosis with PCR. We cannot start treatment with PCR, neither we can stop negative PCR. PCR, because then organism also give positive results by PCR.
Ma'am, the latest workflow, standard treatment workflow also says that any kind of nucleic acid amplification tests can be used.
Yes, that is true. But all your cases, what I want to ask you is that in all unexplained cases, you have only with PCR, you have diagnosed those cases and treated.
In the study, yes.
In the
So,
study, first study.
yeah, in the first study, yes.
Okay. But to
But not that
that
we
is,
did not do other
you
than.
know, because you are thoroughly means the treatment is very, very difficult. Okay. And we don't have also latent tuberculosis till now. We don't have in genital tuberculosis. We have no criteria for that. So
We will now
diagnose
propose
genital tuberculosis to diagnose is very, very difficult. And empirically, we cannot give.
That's
In
no,
that's
ma'am,
genital
what
tuberculosis.
it is a gray area. It is challenging.
It is a very, very gray area. You
Yeah.
have given, you have got good results. But scientifically, how to prove it, I don't know. Okay, I am working in genital tuberculosis for the last 50 years.
Yeah.
And all of you must have read my book,
Yes,
Genital
yes, ma'am.
Tuberculosis for
Yes,
Obstetricians
yes.
and Gynecologists. Means I am in that. And everybody told me that PCR, no question of giving them treatment. But now they are telling that is now the nuclear, that is has come new technology, we can do it because it is very difficult to diagnose ovarian tuberculosis.
Because
Other
ma'am,
places, yes, in
we
ovarian biopsy we
can't
don't
do.
do. We cannot do every time. So
I
what you
mean,
are
we
doing
can't
is
do
quite
only. It
good.
is.
It is beneficial. But try to find out a definite means to diagnose this disease. Okay, because my time is up. You people are coming up, so I thought that I must listen to you today.
No, your
Thank you
time is
very
never up,
much,
ma'am.
and bless you. Keep up the work and send me a paper of yours in my email ID. Okay.
Okay, ma'am.
Madam,
Okay.
please put
Okay.
your mail address here, ma'am. She'll send.
Dr. Nothing. Dr. @gmail.com.
Okay,
Bas.
ma'am. Okay, ma'am.
Okay.
Thank you so much. Thank you so much for joining today.
Honored to have
My
you here,
blessings are
ma'am.
with you. Blessings. Keep on the work.
Thank you, ma'am.
Thank you. Very
And,
kind.
yeah. Dr. Pallavi has asked, like, one of my patients, endometrial tissue was TB PCR positive, and she took treatment for 6 months, has come for an embryo transfer and a ET 6 millimeters triple line after maximum dose of estradiol valerate. Shall I transfer or should I take any more precautions before transfer?
I think this is a scenario where we look at the vascular part of the endometrium, I mean the uterus as well. If the Doppler indices are okay, and if it is only the endometrial thickness which is worrying, if the estradiol levels are okay, and so this was, did you do a constructed cycle with estradiol valerate? What I would do is, I would look at what her endometrium is like in a natural cycle. So if in a natural cycle, if the endometrium is good, the best thing would be to transfer in a natural cycle. But if for some reason you have chosen that she needs to receive hormone replacement cycle, 6 millimeter, as long as other parameters are okay, we can still go ahead and do the transfer. Because sometimes the damage is not completely irreversible. As long as the endometrium is functional, it should be able to support a pregnancy.
Okay. Dr. Priya has asked, like, does thin endometrium correlate with tuberculosis when other causes are ruled out?
Yes, definitely. I think that is one of the things all of us think of first, as long as she has not received clomiphene in the recent few months and no other cause, and she's ovulating.
Okay. Dr. Madhu was asked, like, which is the best tested present for genital tuberculosis when it's done on an endometrial sample?
I mean, rather than thinking of best test, I think the conclusion is that there is no single test which can detect it. So histopathology and liquid culture and any of the NATs you are comfortable with.
Yes. There's another question from Dr. Nimesh, and he's asked, how does histopathology correlate with AMH levels in proven cases of genital tuberculosis? I think that you have mentioned.
Dr. Sheila, all these years I've had one positive histopathology. So I really cannot answer this question honestly. But I mean, one of my assumption is that if somebody's histopathology is showing granulomatous lesion, there must be some structural visible evidence available. So I would say if they have structural damage, they're likely to have lower AMH compared to those who do not have visible structural damage.
Dr. Jayashree Sridhar has said, like, we clinicians should join hands under Dr. Padma, Dr. Tripathi, and form major and minor criteria, including sonography. And if you have read Dr. Ashok Khurana's paper, it's seminal. Example, I made a paper with 400 cases major criteria. That is more than 2 sonographic criteria: TB NAT positive, microbial positive, minor were TB PCR, MAN2, ESR, etc. Okay, so it's a battery of tests and you choose from that,
Yeah.
and the
So
criteria.
it is the consensus statement. Once we write up and publish, it will address this composite reference criteria as well, because that's what we really need. We cannot diagnose based on one criteria.
So can you diagnose ovarian tuberculosis separately? Because you usually take only an endometrial sample. So how do you diagnose ovarian tuberculosis or tuberculosis?
I do not see. I mean, it is such. On laparoscopy, we may find tubercle kind of lesions. You biopsy them anywhere, it comes negative very often. That's been my experience. So I think what we are trying to say is that if we are diagnosing tuberculosis on endometrial biopsy and there is reduced ovarian, otherwise unexplained reduced ovarian reserve in a young woman, we have to assume there is ovarian affection there. So, I mean, if you give me a minute, see, when we talk of gonadotoxic chemotherapy, so how TB can affect ovary? Any structure is, one is damage, vascular damage, fibrosis. So the organ is cut off of some of the precious blood supply and oxygen, so it just withers away. The other is some kind of an inflammatory response that is happening, which can be cured with the appropriate treatment. And then what happens? So what we know in many of the gonadotoxic chemotherapies given in women with very young women with cancers is that, interestingly, why a percentage of them, especially young women, even if they have been given ovariotoxic chemotherapy, their ovarian reserve recovers. Why it is happening is, in them, apparently the primordial pool doesn't get affected. It is the growing pool which gets affected. So for some time we see a sharp decline in the ovarian reserve, and then gradually, once that growing pool has exhausted, and then the new pool gets recruited from the primordial pool, the ovarian reserve starts improving. And I think to some extent that is what is happening. That is my understanding. Like, there is no proof to it, but it's somewhat. I mean, from the longitudinal study we have done, this is the only longitudinal study that has been done so far. So whatever evidence is available there, and it was adequately sampled up to 1 year. It is only at 18 months time, the sample size was below what was aspired for. So there is an improvement in ovarian reserve. I mean, all of us, I think, see that. Somehow, like, AMH is very low and we treat and she has not conceived in 6 to 9 months. And then, out of desperation, we look at her antral follicle count. It is improving. And then we look at AMH out of interest and it is better than what it was. I think all of us have had this experience. So it appears that somehow the primordial pool is very well guarded, unless it is, absolute oophorytis and it completely damages the ovary structurally. So there seems to be a scope for improving the ovarian reserve with appropriate timely detection and treatment. So I would say we are diagnosing with a combination of endometrial biopsy and low ovarian reserve, ovarian affection happening with tuberculosis.
Thank you so much, Padma, for sparing your time. It was an eye-opener for so many of us, cleared all our cobwebs and doubts regarding genital tuberculosis. And I think we'll now move ahead with going more and more of TB PCRs, at least to find out what's happening in our poor reserve patients. And there's only one more question. So Dr. Jayashree, I've unmuted you because I want you to request Dr. Padma to include you in her study on tuberculosis. Jayashree. Okay, I think she's busy somewhere. So Dr. Jayashree and Dr. Tripathi, madam, you can include Padma in your next whenever do your next work on tuberculosis, but because I think they've got a big pool of patients with them. So you will have the discussion will be very this thing there. And there's one more question.
See, TB-PCR, I mean, rural area, still the government provides gene expert free of cost, and in the liquid culture free of cost. So without adding additional financial burden to patient, we can still avail of those.
Yes. And Dr. Madhu has asked, I'm from a rural area and I commonly do only TB, PCR and endometrial. Is it okay to roll out? Yeah.
Yeah, I was just answering that question. TB PCR, but because now that guidelines are there, standard workflow charts are there, at least do a culture without, which the government system will be able to take care of.
Take care of you. Dr. Nimesh Shalat has said a very nice and detailed discussion lead by Dr. Padma Rekha on genital tuberculosis in the current scenario, and thank you for the illuminative touch. Thank you, sir. Thank you for joining today and super discussion. Okay, I think we'll get the recording. Yeah.
Ma'am, one last question.
Yes,
Ma'am,
yes.
will genital tuberculosis patient have symptoms like fatigue, loss of appetite, all that? Does she will have?
Symptoms.
I think most of the time we don't come across these symptoms.
Yeah.
Because
that's
it's
so difficult to diagnose, doctor, because
yeah.
don't have symptoms at all. Yeah.
Thank you, ma'am.
Yeah, thank you. Thank you, Padma. Thank you so much for sparing your valuable time. It was an
I'm
honor
really
to have you.
sorry I joined late because there
No,
was
no.
an emergency, and
It was wonderful talk,
I
ma'am.
just had to hand over things to my colleagues so
I
that
know.
But I'm very grateful to Charmila and each and every one of you. I had no idea that you do such good activity. I'm very, very grateful that you invited me.
Yeah.
And if I
We'll
can
call you
also,
back again once you have finished your next
no,
study.
I would be very happy to be an audience also in this group.
Yeah. And Dr. Jayashree wants to know, like, how can we access Dr. Padma's work? Jayashree, you can unmute yourself and talk.
It
Jayashree.
is I can send it across to you if I have your contact details, but it is available on PubMed. It is
PubMed.
the dissertation.
Sure, madam.
Jayashree is from
I'll mail
Indore,
you.
Padma. She's from Indore. Jayashree.
Okay. Hello.
Hello. I'll mail you, ma'am, or I can message you after taking your number from Dr. Charmila. I would really be interested.
I will send that publication to you.
Yeah. What I meant by major and minor criteria, supposing we take around 10 criteria and say, 2 of the major and 2 minor should be positive, and then you can sort of, lead the thing and, form a consensus.
Yeah.
Like your paper had that
we just
it was
recently-
coefficient factoring each criteria, how much of a coefficient factor you want to give.
Yeah.
It would be really very interesting. It has been in my mind for many years. That's why I found your talk very interesting.
So we had a consensus only addressing 2 questions: how to diagnose and when to investigate. These were the only 2 questions we discussed for 2 days, and we have come out with
Yeah, excellent.
hopefully I just need to put my head down and write that and
Thank
try
you,
to
Dr.
get-
Charmila, for organizing this. Yeah.
Thank you, Jayashree. Join often, huh? Don't come only for tuberculosis. Okay. Thank you, Dr. Padma. Thank you so much. It was an
thank you.
honor to have you. Thank you to all the participants who joined today and for that very, very great interaction. Thank you, Shield Pharma, for the support. Thank you, Sagiti. Thank you so much. We'll meet again next month. Thank you, Dr. Padma. Thank you so much.
I'll take your leave now.
Yeah.
Thank you. Once again, very grateful. Thank you.
Thank you.